Coastal Healthcare. This is Dr. John McCormick with my co-host today is Peter. That's pretty much always, you know. And we're going to wrap up the series about why Americans pay more for healthcare than any other nation in the planet. And today we're going to focus on two topics. We're going to talk about pharmacy, which of course means we're going to talk about the evil, quote unquote, pharmacy benefit manager and private equity. So that's what we're going to focus our little conversation on today. Not going to be a very long episode, but I think it's an important episode because a lot of times we don't understand the different layers and things that are going on.
This is, for me, a hot topic as I've gone to the pharmacy and found different prices. And then the fact I get other prescriptions added on top of to take care of the first prescription that they gave me, so that all of a sudden you go from 0 prescriptions to 1 to 7, and you can't get a consistent price.
Well, and I talked about in a previous episode where most countries that are developed countries, the population is on 0 to 1 prescription, sometimes 2 for the European countries. Americans that are middle age and up are on 6 or more. Right? Now here's a little news flash for you. One of the things that we don't test for in the industry and should is, does your body actually metabolize the medication that you've been prescribed? So depending on your genetics, you might be getting a prescription that literally does not metabolize in your system and has 0 effect. All right?
What would be involved in a test like that?
There's actually genetic tests that are available. So, but it's really not valuable from a plan perspective, especially if you're a plan that's getting paid on every side of the equation. Why are you trying to cut down the number of prescriptions you're getting people? You're not, right? So really, you're talking about people like us and other plans that are like us that are really trying to be good fiduciaries for the member that says, you know what, this member is on 10 medications. How many medications are they taking to offset another medication? And of the 10, how many are actually valuable? So then it's worthwhile to go back, and pay for that metabolic testing so that we can get a result back that says, of these 10 medications, these 4 are the only ones that are working. Now we can go, okay, let's take these 6 off the table, go back to the primary care doctor, hopefully, and have a real discussion about the right way to come off the medications and reduce it, because as you know, they may not be metabolizing the good effect, but they could have all the side effects. So you've got all these withdrawals and all the other downsides to these meds.
Dr. John, that is a great piece of advice, and it's significant for the people that are listening, that prescriptions and drugs don't necessarily work at all, even though with all the best intentions, it's got to be tested.
Right. And sometimes, I hate to say we call it medical practice, not medical science, although there's a lot of science involved, but sometimes it's practice. Let's try this. But sometimes when we're trying this and then we go to try the next thing, we forgot to turn off the first thing. Or the first thing didn't get turned off for whatever reason. So you end up with this stacking effect. And so you really have to be aware of that. And you also have to have a physician that's, that knows you and is willing to have those kinds of conversations. Unfortunately, with the way people change plans and, your doctor might have been in network with this plan and now they're suddenly not in network. So you're losing your continuity of care. Or let's be real honest, some people doctor shop. I want this drug, whatever it is, fill in the blank, right? And their first doctor they go to goes, you know what, we ought to do this first. No, I saw the commercial and that's the drug I want. And they start to doctor shop. They're not doing that for health reasons. They're doing that because of the programming that's coming through the TV, and we're one of only 2 nations in the world that even allows that kind of advertising.
I was going to say, prescription advertising, drug advertising is so pervasive in the U.S. media, and at the same time, it's a wild west over at the pharmacies as to what's being filled and how much they're charging.
Oh, absolutely. And we talked about this a little bit yesterday, where we said, you've got all of these different pharmacy prices depending on where you go shop. I mean, I was just looking at a drug this morning. So we got a contract for international sourcing. Why is that important, right? Why do I have to go outside the United States to ship a drug over and pay the shipping fee to buy something that I ought to be able to purchase in the United States? And the reason is because if I bought the same drug in the United States, it's $500. But if I order it from overseas, it's $50. So, okay, I paid $25 in shipping. I got $75 cost. I'm being a great fiduciary for my plan. I'm being a great advocate for my member. I'm getting them the same drug at substantially less. Why wouldn't I do that?
We have to.
And it's a shame that we have to.
Yeah.
The fact that you said we have to just burns me up. Why do we have to? Why can't we not give the same rates, to our customers here in the U.S. that are given in every other country in the world? Now, I know the argument for that. It's a kind of a rhetorical question. The argument is, well, the United States develops the drugs and we spend all the R&D and da-da-da-da-da. And so the people that are doing that research and development and coming up with these drugs spend billions of dollars and they need to be able to recoup that and so on and so forth. And I'm like, okay, cool, I get it. More power to it. I know it costs a lot of money to get a drug, developed and researched and then approved and all that stuff. But why should America shoulder the burden for all of that? I mean, if we're developing the drug and the world is using the drug, should not the price be at least compatible across all nations?
Absolutely.
So that's the kind of stuff that makes my head hurt. And, some drugs we develop here, research and development, but it's actually manufactured overseas. And where it's manufactured, it's ultra cheap. And then by the time it gets over here, it's suddenly ultra expensive. But just talking about international sourcing, I can go to where it's manufactured and get it ultra cheap. But somehow our pharmacy benefit managers and the United States government that spent billions of dollars, more than what a drug actually costs, I don't understand.
Well, Dr. John, one of the things that I think a lot of people have a difficulty understanding is the articles that have been in the press about the markups on drugs and drugs that are past their protected period for development, and companies that have marked up thousands of percentages points to make the price higher, so it's just pure profit. There should, in my opinion, be some restriction as to, once it's off that protection, more of a standardized price.
Yeah, again, we don't want to get into, this is the price cap for things, but I think there's a matter of reasonableness. What is reasonable? What's a reasonable expectation for a person to have to pay for a medication that they need? All right? One of the studies that we were reading, there are 224 cancer drugs that are approved by the Food and Drug Administration between 2015 and 2020. That's a lot of different cancer drugs, right?
Yeah.
Cancer is devastating. Financially, it's devastating emotionally, and of course at the cost of life, one of the largest killers in the world, right?
Right.
You know what the average cost of those medications are per year per person?
I don't have a clue.
Almost $200,000. So not only now do you have a life-threatening disease, the drug that they're trying to give you is well beyond what the normal person makes sometimes in, 10 years.
Yeah.
Right? And then if you go, well, the insurance company will pay for that. Well, sure they do some, but ultimately we all know, because we can look at the profits that the insurance carriers are making, that price is passed on to everybody else in premiums, right? So
Exactly.
is that drug really that expensive? I think we would probably, when we peeled it all back, would find out, no, it's not. You know, what we're paying $5 or $10 or $15,000 a month for is available overseas for $300, $200. You know, in some cases, it's pennies on the dollar. And those are the kind of things that just, almost physically make me sick to say, in America, we're charging, this amount of money. And if I just drove across the border to Canada or to Mexico, I could really get it at 100th of the price.
That, I know a number of people that are in their senior stages of life, and that's what they have to do in order to get the drugs. They have to go to a different country, develop a relationship, and have their medications filled.
Right. Let's talk about some of the drugs that are on the bubble right now, right? Ozempic, Wegovy, they're all made by Novo Nordisk. And you think, okay, in America, those are cost prohibitive. Cost prohibitive, in fact, that a lot of commercial plans completely excluded, unless you're a type 2 diabetic and a lot of other things. They don't even want to touch that because it will literally destroy a small or medium business's plan, just being overwhelmed, that you start to pay more for pharmaceuticals than you do for surgeries and hospitalization. And it should not be that way, and yet here it is, to the point where, in Ozempic, the cost can be between $900 and $1,000
A month.
a month, right? Same drug in Canada, $155. Same drug in Denmark, $122. Germany, $59.
Why?
Question mark, right? Because we're the saps, I guess, Yeah, U.S., we're the suckers, First of all, that we would even think that we should pay that price. And second of all, that we subject ourselves into a system that doesn't allow us to seek and get the best rates. So unless you have somebody that's innovative, that understands the pace, that knows that they can get those things internationally and they can bring them into the country or get them compounded and get them at a much reduced rate, then that's where you are. You're either stuck with the denial or you're stuck with, some kind of copay or co-insurance. But if you're in a co-insurance kind of scenario, a lot of times these co-insurances are 50, 60%. Well, I've got to pay $500 over $1,000, but if I went to Germany, I can load up for $60. It might be cheaper to fly to Germany and fill my prescription. I don't know.
The other side of that is the people who need the drugs and yet can't go and buy them or afford them because they just can't get there.
It really is. It's insane and it's sickening. And it's insane and sickening, that we know what the manufacturing and initial procurement cost of these drugs are because, anybody with a browser on their on their laptop can look at a medicine and see what it's priced in other countries. And then they really should take a step back and say, if it's X in this other country, why am I paying 10 times, 15 times, 20 times the rate? Same as your example in the last show. Why is it that if I'm standing in the pharmacy on the right side of the street, it's $200, and on the left side of the street, it's $25 when it's the same medication?
Uncontrolled chaos.
It really is. Right? Which kind of leads to the next part, right? What contributes to the chaos? Private equity. A lot of times we talk about You know, when we're talking about our plan, we say, if you like your doctor, you can keep your doctor. And we really mean it. You know, it's not just a catchphrase. We want you to have continuity with your physician.
Yep.
There's not only some care rules that go along with that, that, you know, if you have some kind of comorbidity or long-term disease, that your physician is required to continue to see you and those kind of things. And it's our job as a plan to make sure that that doctor's reimbursement is equal to, and in some cases better than, maybe the plan that that member came from. And so that's part of our goal, right? But sometimes when we reach out to these providers' office, we get the, we can't take your plan. You don't like money? We're offering you the same money that you were getting from that major carrier. Yeah, well, we can't take your plan. What they really aren't telling you is we're owned by private equity and we don't get to choose who we do business with. We can only do business with those people that private equity has told us we can do business with, because that's the ones that private equity has told us will make us the most money or make them the most money, because at this point we're owned. So we're just a salary to some, you know, major private equity firm that's on Wall Street that is using my doctor's office, my hospital, my lab, my, pharmacy as a piggy bank to enrich themselves instead of delivering high quality care at a fair price.
Well, as many people have experienced, when you start talking about stock and Wall Street, it's purely a greed factor. The shareholders are who they manage the companies for, not for the public good of the services that are selling.
Right. I mean, so here a local Texas deal, Federal Trade Commission, actually sued U.S. Anesthesia Partners, all right, for serial acquisition practices in Texas, alleging that these deals violated antitrust laws and inflated prices to patients. So this is an example of private equity. Remember, we always talk about the anesthesiologists aren't in anybody's network?
Yep.
Well, this private equity went bing, 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 money, 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 money. We're going to buy up all these anesthesiology practices and jack the rates because there's no competition and there's no network. Talk about antitrust, right?
Right.
So here we are. Is that somebody that's looking out for you, the patient? Do we need anesthesiologists? Yes. Do we want to compensate them fairly? Yes. All right. But when they're owned by somebody else, the anesthesiologist that's treating you doesn't get a vote. I can almost guarantee you that their compensation did not go up, just their charge.
It's a salary to them.
Yeah, it's a salary. They're being paid a fixed rate. All right. They're just getting, and they make a tiny bit of money. It's the upcharge on top of that that's going to the administrators and the private equity group that's driving up the cost, not the guy that's actually got the skills that's performing the service.
When the CFOs are doing their planning and their budgeting, they build a profit into that budget that's pretty significant to start with. Now, as opportunities come up during the year, they go for the greed cycle and try and get as much as they can at our expense.
Right. I mean, they go on to say, of course, the rapid acquisition allowed the investors, all right, to raise prices and actually generated tens of millions of dollars in additional revenue. In other words, profits that went to their bottom line,
Exactly.
at our expense.
Exactly.
At our expense. And we should be so angry about that, and we're not. We should be screaming from the rooftops that we're allowing, and I say we, because collectively we are allowing this to happen, and we're allowing it to happen by repeating the same mistakes over and over again, thinking that, the major carriers are our friends and the doctors' offices that all have the same brand on them are, looking out for us and helping us reduce rates, and we just don't have the transparency to know, well, you think that's your doctor, but your doctor, that's not anymore. That's Wall Street's doctor, and you're paying twice as much than you would if you went next door to the private practice.
Well, you've got the drug companies doing all this advertising and trying to drive demand from the consumer back into the doctor. And at the same time, the doctors are getting all these fees and speaking fees and articles, different ways that they're getting additional compensation themselves. Combine that with it's being paid through an insurance company, which is also a for-profit company.
Right.
So you start building in those layers of profit by services being used, and we're being raped, pillaged, and plundered.
Every way but Sunday. And there's nobody that's honest in this business that will tell you that there's not, one, lots of flaws and how it's put together, and two, lots of opportunities for improvement. And I think the role of the innovative broker, the innovative benefits manager, the I'm going to say awake employer or employee is to really seek out those plans and third-party administrators that are actually being good fiduciaries and actually saving money. And the way you're going to be able to identify them, I hate to say, is so easy. They're going to be completely transparent with you. They're going to share their claims data with you, or what I would say, your claims data with you, right? Yep. This is what you were charged. This is what we paid. This is how the price. These are the prices that we negotiated on your behalf. Had we not done this, you would have paid $10,000. But because you allowed us to advocate on your behalf, we got that same procedure or something for $2,000. So it should be very apparent to you what your plan fiduciary is doing for you, because ultimately it's your money. And, yes. If you're just firing and forgetting, I'm just going to write the premium check every month, we'll expect your 10 or 15 or 20% rate increase every year, but don't expect services to get any better, and don't think you're ever going to fix the system. In order to fix the system, you have to be willing to step outside.
With the costs and the premiums being what they are and continually going up, it really behooves everybody to get educated onto the system so that they can get the best dollar value. We're talking about virtually the price of a car every year.
Oh, you're exactly right. I literally saw a quote today: a renewal for a small group, 30 life group, right?
Yep.
Middle end. Yeah, these are not high level executives. These are, middle income kind of company, major carrier renewal for this group, and this. So I'm going to break it for a $6,000 deductible plan. Their rate per employee, $891. Your heart just stopped, didn't it? $891 for a $6,000 deductible plan. So they're going to pay almost $10,000 a year per person, and then that person still has a $6,000 deductible before they even have any real coverage. So they're paying $10,000 for one free medical visit a year.
It's criminal.
It's criminal. It really is. Anyway, so when you wonder why Americans pay more for healthcare than anybody else, a lot of it is that we've been conditioned to do that. All right, we're not willing to ask the hard questions because it's complicated, and we've been told it's complicated. And when we experience or we try to engage the system, it is complicated. But we have to understand it. First, it's complicated by design, but two, there are lots and lots of experts in this business that, like us and other folks that are like us that do this kind of thing, that are really out there trying to shift the Overton window away from doing things the way we've been doing them into ways that are cost effective, that still deliver high quality care.
Well, the day has changed where it was a part of working for a company and you get all these benefits and insurance, to now it's really the far free west fighting because every time there's a change, it's taking away from the employee.
Right.
It's not adding more to it.
Deductibles are going up, co-pays going up, co-insurance is going up. Well, your plan cost didn't go up this year, but you have to pay more out of pocket. Well, then my plan cost went up.
Yeah.
All right.
Or your deductible went up on top of it.
Right. So it's just like not connecting the dots.
There's different levers the insurance companies pull to make sure that they guard their profits.
Absolutely. All right. Thank you, everybody. We'll see you next time on the Pulse of Healthcare.
Thank you, Dr. John.